Bueno, solo para dejar registro, nos encontramos hoy, 19 de octubre, en este ciclo de discusión de textos y de presentación de resultados del grupo de estudios sociales sobre fármacos y diagnósticos, para compartir y escuchar la presentación de Gabriele Cerati, que está aquí presente con nosotros, An Epidemic of Depression, Preliminary Results from an Ethnographic Study in Two Italian Outpatient Psychiatric Clinics. Hice lo que pude en la pronunciación. Did my best. Te escuchamos, Gabriele. Muchas gracias.
So, hello everybody. Thank you for being here. And we already hear the title. I'm doing my PhD in Italy in sociology in the University of Milano-Bicocca. And this is more or less the sketch of my whole thesis. I will see what I can present today, how much time I have and everything else. So, of course, you know, I'm speaking about depression from a sociological perspective, as I'm a sociologist. And so first, just a little bit the outline. I will show you the background of the research questions, the presentation of methods and fieldwork, some results and theories also associated to these results, and the discussions and implications for this. So, so the background of the research, the epidemic of depression, is what it is called mainly by the academia, because we have a high increase of depressive diagnosis in the last 40 years. And specifically in the last 10 years, we had 11% more and become the second largest contributor for health loss. And so this made the depression more giving more space in both scientific, political, and economic discourse, as well in common sense. So it become like recognized as a social problem, even though like it's something, as we know, addressed by medicine mainly. There is interest more and more about the social dynamics involved in the rise of diagnosis. So a little bit of data, just some quantitative data. Like this is a division by WHO world regions, and we see how these are more diagnosed like in the European region, and the region of Americas will be like the whole continent. This is like the WHO division, but yeah, compare for instance to Southeast Asia or African region. And so this, just the background, the epidemic of depression, we have two types of sociological explanation that are used to explain and to give sense to this epidemic. I grouped in two groups. One is the social condition and processes that brought the increase of prevalence. So there is like social change that brought this increase. And the other one is the opposite. Instead of occurring more frequently, depression is diagnosed more and more all over the world. So it's not a question of like social condition and change, but it's a matter of diagnosis. Of course, these two theories can taken together, so we don't have to choose between one of the two. The social explanation, as I called it, talks about the increased competitiveness and demand of self-realization, and the relation of social cohesion as a protective factors against losses and adverse events. So there are some changes, like specifically in the way we think about ourselves and our demands from ourselves, as well as like secularization and social disgregation processes. While the diagnostic explanations say instead that we have like some changes in the way we are thinking about it. So the advancement of pharmaceutical market, the spread of the concept through media, professional public discourse on the disorder that can describe these times, and the misclassification of common sadness as depression. So these are my research questions, basically, for the whole thesis. Coming from the general question, this is how can we explain the epidemic of depression, that I just show some answers, theoretical answers that I took from other authors. Then we have two perspectives. The diagnostic perspective like you see, there is like the social dynamics involved and the diagnostic dynamics involved. So I took like these two paths. The first path is the diagnostic perspective, is like considering which with the perspective of diagnosis and medicalization of depression we have in to understand. And the other part is the social perspective, so understand like social dynamics involved. For the diagnostic perspective, we have which representation regarding depression do professionals have. So I study professionals, what they think about it, and also, of course, how what consequences it has for the treatment. And for the social perspective, we have like which social factors are connected to the emergence of depressive symptoms in patients. So in this case, I'm studying patients. And how can different social conditions and events be involved in the two syndromes? So medicalization, professionals, social condition, and patients. Then I will show again this. For the methods, I used 1 year based fieldwork into psychiatric facilities in the city of Milano. I did 28 interviews with mental health professional, participant observation in psychiatric interviews, so like the encounter between the patient and the doctor, and everyday activity as well. Around 200 interviews for 6 months. Out of these 200 interviews, I selected the patients with depression, and I took the clinical records from them, basically. So the fieldwork I did in the city of Milano in Italy, which is the second biggest city that has 1.3 million inhabitants. There are 15 outpatients clinic for public, about 4 public hospitals. So they're like 4 companies which are like working as the public system anyway. So like they are like providing services as public system. They get reimbursement from the government basically. And there are 15 outpatients clinic which are like connected to these 4 public hospitals. For outpatient clinic, I mean these clinics where patients come and go and do not like stay in the clinic. They are just going for any kind of service they need for their mental health, but without like being hospitalized or like living or sleeping there. They just have access based on residency. So it means that there are 15 around the city, because now psychiatry should be like territorial. So it should be like that it goes towards the patient and not like the patient that goes to the hospital. So according to residency, there are like 15 areas in the city, and the patients go wherever they need to for having some services like psychiatric services, for instance, like diagnosis, treatment, or just visit encounters and so on, psychotherapy, but even like help from social workers for the socioeconomic condition, as well as nurses and educators that do like the resocialization part for people in needs in that sense. So, coming again to the question, now I will show a little bit the results, directly the results from the diagnostic perspective. So, the representation regarding depression and the consequence for clinical practice. As I said, for this, I used mostly, because I mean the methods, the ethnographic part, the participant observation as well, the interviews are like together. But for this part, I will use mainly the semi-structured interviews that I did. And I interviewed all the people in the clinic, not all of them, but most of them. And but these results will be specifically for psychiatrists, what I'm showing. So just to show, I mean, I don't think you need to see it again, because I think that most of you can know this, but is this the DSM-5, which now is DSM-5-TR, but still it's the same. DSM-5 definition of depression. So the list of symptoms that the person should have to be diagnosed as depressed. Just to show, because then we can think about it, about the fact that it's like very strict and how you say structured definition to see if like it fits or not. Then another thing that I should have to show to discuss about concepts, reactive versus endogenous depression. So depression can be reactive, so like a reaction of adverse life events, like losses, breakups, changes in working condition, economic and housing problems. So there is literature that says adverse events can trigger depression. So they can be like problems in that sense. While other things that should be some part, at least, of depression, which is called endogenous, so like without causes, let's say causes, because in psychiatry we don't have causes, we have risk factors, basically, due to imbalances inside the brain. So why this is important? Because if there is the recognition of adverse life events, there is the recognition of social dynamics in the occurrence of depressive disorders. Back to the concept as well, I don't think that I have to explain to you, but the biopsychosocial model considered both the biological, psychological, and social factors involved in the mental disorders, while biomedical model is considered mostly or uniquely the biological part, so considering biological entities to address with the pharmacological treatment. So just these three concepts, because now we will discuss, and I will show some extracts from the interview just to discuss about it. So as I said, I showed the DSM part, the DSM definition, and from my interviews, psychiatrists say that depression should not be considered like something. It's something way more complex than the definition of the DSM that we have. Like very complex phenomenon that sometimes we're speaking about symptoms, sometimes about syndromes. We're speaking of many things, and the signs and the symptoms are very different one patient another, and everything. So it's very hard to define as a single entity. Of course, we can understand each other while speaking or about the symptoms, but it's very hard to describe the syndromes. It's way easier just to think about the symptoms involved in a patient. Depression as a reactive disorder. All the people that I interviewed recognize depression as a reactive disorders, both psychiatrists and psychologists as well. Some psychiatrists think that depression is always a reactive disorder, while some other thinks that there are some situations in which depression can be endogenous, but still most of the people recognize the reactive part as very important. This is interesting because in this case, of course, it seems that psychiatrists are very much considering. You will be maybe surprised, I don't know, but in my research, I was surprised as well. I thought to find like biomedical psychiatrists, but I didn't. And now it's also what I want to discuss with this. From my observation and from my interviews, I always like had the same path of like what the psychiatrist told me about their like education. So they got like a very biomedical education through the school, through the medicine university. And then when they go out of their school, they go to the clinics, specifically this kind of clinics, where the outpatients, when there is this multidisciplinary keep, and when people has some like reporting problems that are not mainly biological, but there are like intersection of psychological and social problems. So they just, in that sense, they just realize that their knowledge is not enough. And so they have to learn about recognizing these other parts. And so everybody was agreeing with the biopsychosocial in the end. And like considering like impossible to think just the person only through the biomedical model. But in the end, like considering about the practices. So as I said, like I was studying the representation and the practices associated to this. So if the representations are like, I said, if the practices are like following the representation we have. So as I said, if the biopsychosocial model is considered like true, there should be at least psychosocial intervention for depression, because as I said, like it's recognized as a reactive disorder, but this doesn't happen. I mean, social intervention sometimes like are addressed like just giving basically money or like trying to fulfill the economic needs of a person. But apart from this psychotherapy is not much addressed, for instance, because of lack of resources. And while the pharmaceutical treatment is way more convenient for everyone, like in terms of it's very economic for the patient, it's directly available, it's very economic for the how you say, the system, because we are covered publicly with pharmacological treatment, while we aren't for psychotherapy. Psychotherapy is, of course, addressed in services, in psychiatric services, but it's very scarce and directly specifically for the one who need the most. So it's very hard to get public psychotherapy in that sense. Just summary of this part. The DSM's, just about diagnosis, DSM-5 symptoms are not enough for clinical practice. Psychiatrists recognize that the boundaries of depression are like blurred, and they need something else to understand it. Biological psychiatry still dominates academic training, but then is compensated with other skills acquired later because it's insufficient. Depression is considered by mental health professionals as a complex and multifactorial distress, and there is this holistic view of mental health disorder through the biopsychosocial model. For what concerns representation and practices, while representation of depression moved from the biomedical model, which nature says that it was like dominant, to the biopsychosocial model, treatment practices are still mainly bounded to the biomedical model, involving pharmacological treatment. So why? Because of the practitioner role, like the doctor think they are doctors, so they have to act like doctors, like giving prescriptions. For the biomedical training, still that I say representation switch, but the training is still there. For legal protection, because still there is this idea that if the patient is taking medication, they're like legally protected from anything, even though there could be important like other types of intervention. For the scarce availability of public psychotherapy, and also because pharmacotherapy, as I said, is an easy and affordable option. Okay, coming to the second question. The social perspective is something that I already presented in another presentation 2 weeks ago, but for the ones who weren't there, like which social factors are...
Gabriele, el público se renueva, dice por
sí,
acá.
Sí, sí.
The public changes all the time.
How much time do I have now?
Vas muy bien. It's only 10:30 now. 10:30, so.
Okay.
We are okay.
Let's go. Okay. The social perspective shows like which social factors are connected to the emergence of depressive symptoms in patients, and how can different social conditions and events be involved with these syndromes. So we have participant observation and clinical records that I say that I observe. So this part is mostly connected to this. So social factors connected and social connection in syndromes in patients. So this is patient side. I observed the clinical interviews, which are, as I say, psychiatrists are the first professional who see patients and manage their treatment and get to give patient access to clinical help and service. We have the clinical interviews is like a 30 minutes face-to-face interaction without test. There are questions about everything like psychological, physical symptoms, everyday life, personal problems, socioeconomic issues. And all of this is reported in clinical records. So the patient is speaking about their like socioeconomic issues. And so I could take them as also reported in clinical records. It's important because not everything was written in clinical records, and vice versa. Sometimes like attending just one or two or three even or more interviews from the same patient as well, because for some patients I attended more than one. You cannot see everything from like one encounter. So it was important to have tracking everything in this way. Yeah, these are the two areas that I studied. The two areas are, as I say, the interviews have been like placed also in these two areas, well, into these two hospitals covering these two areas, in which there are different degrees of poverty, unemployment, house ownership, migrant population, and level of education. So in these two areas, they are like covered by the same hospital. So I took like the more deprived and least deprived area for these for the same hospitals. So where there are these two clinics. So for as I said, like there are pretty much different conditions, and the idea is that if I see two different conditions, two places with two different conditions, I will see like the most distant cases and see what's in common between them anyway. So just going straight to the results. These are the dynamics that, these are the dynamics that I've seen that I observed in the two contexts. They are divided in 4 groups. I divided into the transformative situations, where like there is some transformation for the person, life event, bereavement, breakup, health issues, retirement, widowhood. We have relational issues, stress, and trauma. So like other problems, then you might understand more why I divided in this way. Like family situation, conflict of familiar relationship, intimate relationship, problems in family, problems even sometimes in work, and mobbing. Socioeconomic disadvantages, so like dismissal, unemployment, displaced from original context, economic deprivation, gender roles, single parenting, social isolation, trials and jail, and unstable housing situation. And the last part is like expectation, frustration, and existential meaning. So like autonomy, individualization, all these things concerning the idea of that a person have about themselves. Expectation from the family, working expectations, or mostly expectations. So the condition that I observed, even though they are two different contexts, I found most of them in both the contexts. Okay. I just divided according to a theoretical division of which situations can provoke distress. Okay. However, while the conditions are in both contexts, some of them are in balanced way. Some other are affecting more one context compared to the other. So I divided them in context independent and context related. Like the first group, see all these situations where the people are like affected independently for the place where they were living. Of course, like substance abuse in a rich and poor area can be different in terms even about the substance used, but still it was like something that you might find in both ways. That's why I put it like here. As well as health issues, or like, I mean, we know that we have different rates for this, but what I want to say is that this could be found in any context anyway. While the second ones, they were anyway found in both contexts. The socioeconomic disadvantages sometimes are affecting people even in richer area, and vice versa. The expectations doesn't mean that somebody with socioeconomic disadvantages cannot have like frustration according to expectations. Could be even that also triggering that as well. But they are context related in terms that they are more easy to find in some situation compared to the others, for instance. So for this second part, the interpretation of the results, I give like three accounts, just perspective, because it's very hard to say, okay, let's give like a general theory about. So The first one, see the materialistic and post-materialistic needs. So as we have seen here, there are like some needs concerning the socioeconomic disadvantages that are considered materialistic in terms that they are like more bounded to the material condition, and some other that are post-materialistic that are like not bounding to this, but they are like more related to something more concerning the self and the ideal of the person. I started from English hard materialistic versus post-materialistic shift. So like there is this idea that the fulfillment of materialistic needs brought people to consider like more relevant also post-materialistic needs, so like the self-determination. And this reminds also the Maslow hierarchy of needs, like where self-actualization comes after the psychological needs. Concerning this, I say that I don't believe that there is like actually an hierarchy for this. It's just useful to remind there are like two different things, but we cannot say even Maslow was like theorizing this, but not proving that self-actualization comes after the physiological needs. So just to give like a distinction between the two. Then Ehrenberg, the awareness of self theory, which is very famous, and start from Freud theory about mourning and melancholia. So the idea is that there is this overlapping of symptoms within bereavement and depression. So as the symptoms are the same, Freud theorized that we are experiences a loss. And the loss can be not just for a person, but in general for another significant object, like it could be conscious or unconscious. For unconscious, for instance, ourselves, our expectations, our way of thinking ourselves. And Ehrenberg suggests that this is intrinsic in contemporary society because there is this coexistence of concept of responsibility and spirit of initiative. There is no more the Freudian guiltiness and discipline society. We have to be ourselves. We have to arrive to be the best of ourselves, and we have limitless possibilities in terms that we don't have anymore the some sort of regulation in the way of behaving. I think at least less of this, but we can realize our potential, but we also have to do. So we are basically the society are demanding individuals to take initiatives and realize themselves. There is like this gap between what we are and what we want to be. And this also make the emergence of depressive symptoms. And individualization and secularization processes leave no room for the experience of the loss in that sense. There is no possibility to fail, let's say. Last one, humiliation and treatment theory. That could also be connected to the other two. When individuals experience life events involving loss combined with feeling of humiliation and entrapment, they are more prone to developing depression. And this like happens when people are losing person, jobs, properties, opportunities, and all this. So the psychological and social part here are connected together. Of course, I'm coming to the end. Of course, as we see, we have inequalities in terms of the way we have different problems affecting people and having different having depressive symptoms, even though they have like different path. It is also interesting to take in account the differences in means to overcome depression, not just in the way for the reason that people are depressed. Some of the reason, of course, like a social part. We have different means. So like in economic, social, and cultural capital, according to like Bourdieusian division, in economic capital means that people, if they have more money, they of course can overcome some of the social economic problems that they have, and also they can also get private treatment, for instance, get private psychotherapy. And so this is very important to overcome depression. The social capital, not feeling alone, not to be alone, is very important, and also can be helpful to overcome some other problems, like economic problems, for instance. And the cultural capital, because we know that the health literacy is providing people different ability to take in account which problems are considered like problems, so like recognize their symptoms, for instance, and they can manage to know where to get treatment and so on. They're like more able to get help for this reason. And so this disadvantage is cumulative for lower strata, because we have people that are facing socioeconomic issues that other people are not facing, and also they have less means to overcome this, because they have less economic, social, and cultural capital for most of them. So I just also give two other means that are important to overcome depressive symptoms. One is the importance of access to psychiatric outpatients, clinic, and welfare services. So like having the possibility to get to this clinic is very important, because they're free, mostly free, or like very, very small amount of money you have to pay. And also there you can find like welfare services. So like for the whole socioeconomic part, you find like social worker that can help you. Or like programs to find a job, or programs to like, how you say, thinking about like a future and so on. And then there is also important the clinical help and therapeutic relationships, in terms of the fact that like the therapeutic relationship is like substituting the social capital when it's missing for some people. As I said, also this is something specifically for psychotherapy. Psychotherapy, as I said, is more as the pharmacological treatment is available for everyone, but the psychotherapy is more likely to be used by most educated and wealthy, because of the scarcity of public funded psychotherapy in Italy, the high cost of private psychotherapy, so people who don't have means cannot afford it, and the low socialization to psychotherapy for lower educated classes. So as I said here, it's like there is also like levels of inequality and exclusion to this. Just to come to the end, what intervention can we expect to reduce the emergence of depressive disorders? Of course, the fulfillment of economic and social needs, as well as the cultural changes, promoting healthier discourses regarding self-realization and life goals. Why I state this? Because the economic needs are, because a part of the literature is considering like the socioeconomic condition that are involved in this, and that's super important. But we don't have to forget about also the other part, like the cultural part, so the way things we are thinking about ourselves and our realization, and this should be like there should be intervention in this, because some discourses are on the contrary promoting more depressive symptoms, so there should be like cultural change in that sense. Thank you.
Thank you very much. Sophie. Starts clapping. Okay. Thank you very much, Gabriele. I have some comments and questions for you. They're very diverse, so I don't know if anyone wants to share with us their opinions on the presentation before, so Gabriele can have a feedback in general for his presentation, and then we can deepen in the specific questions and comments. No? Well, I have different questions, and some of them were included in our meeting 2 weeks ago, but the public changes, so yeah. I can ask you again, and we can restart that conversation. So the first one I want to ask you is, because when you talk about reactive and endogenous representations on the practitioners, on the professionals, I wonder, it's only a question, I wonder, because I remember my own fieldwork on ADHD, that there was another type of representation, mainly in this case, located in neuroscientists, who included the social situations, social conditions, social problems, but they included them in a biological view of the problem. And they talk about predisposition or another type of concepts to join both, not like a very distinctive thing, like is social or is biological, but they included them, saying that some people were more predisponent. Sophie, you can help me if I'm not talking very good. Predisposed, okay. But say we can, in the same situation, some people develops, in this case, ADHD, and we can wonder if develops depression, and in some other, no, it doesn't. But they included both types of explanation. I don't know if I'm being clear enough. In that case, maybe I can rephrase something. Did you, in your research, did you find any of these arguments on including both?
Yeah, I will answer now, right? Yeah.
Yes, of course.
So yeah, yes and no. I mean, I think that's some thing that psychiatrists, but in general, we should like take into account every condition, like as it said. As also I was showing in one of the interview, they're like also speaking about depression as reactive, specifically on depression and anxiety, like I say the common and less severe problems in that sense as these. I think that ADHD has considered like a neurodiversity has way more, at least more biological representation of that. Even though predisposition was always taken in account and familiarity and some of the biological. Sometimes I was a bit skeptical also about the way they were also speaking about it, like because I mean, speaking of like familiarity or other stuff, it's like you have at least to prove that. It's very hard in any sense to say which, also for like which condition are like even the social ones. We cannot be sure. These that I showed are like relevant. I'm like people are saying that relevant. The doctor says that they're relevant, so I'm like considering that as something that we might say is relevant in that sense. But like, of course, you should maybe go more into the psychoanalytical part of a person to understand this more in a way complex way. But yeah, they're still considering the biology itself. They're sometimes mixing, sometimes not mixing the discourses. It was trying to guess, let's say.
Yes, that's why I pointed out that it was related to ADHD in the case of my fieldwork, because I acknowledge there are different things. But Esteban, would you like to?
Después de terminar.
Okay. What I meant is, not all the biological explanations were reductive. They were very eager to prove that they had a different type of approach to the biological explanations in an open way, saying that you can express or not that thread. I considered, you know, Gabriele, I mainly study the professional discourses. So my main achieve is to incorporate the most all the nuances as possible. So I like to incorporate not only that polarity, but the discourses that include a different view of the biological aspect. That's why I ask you, in case you find anything like that in your research. So Esteban, you wanted to add something, or maybe?
Sí, también solamente hacer unos comentarios, que ya me voy a tener que
Por eso,
retirar,
cool.
porque por eso agregar unas cositas nomás, solamente, bueno, agradecer a Gabriele por la participación, la verdad que me encantó, ya lo había escuchado hace poco y también porque, bueno, no solo por todo este, parece que hay mucho trabajo de campo detrás, muchas entrevistas, observaciones y esta vinculación, ¿no? En la interpretación de los datos entre la teoría y, bueno, el material empírico. También a mí me genera mucha, lo hablo en español porque en inglés voy a estar
Sí,
más
sí, we are learning.
complicado, pero no sé si me seguís, Gabriele. Eh, Además, me encuentro como muchas similitudes con mi trabajo de campo. Si bien estuvo hecho acá en Santa Fe, en Argentina, seguramente la tradición de los saberes expertos son diferentes en más de un sentido. A mí me sorprende la similitud en las maneras o muchos aspectos en común en la manera en cómo dan cuenta de esto que podría ser como una especie de epidemia de la depresión o representaciones sobre ese sentido. Entonces, bueno, a partir de ahí creo que me surgen muchas preguntas, ¿no? Acerca de por qué esta semejanza a veces en lugares eh, tan dispares. Eh, También esto, lo endógeno, lo exógeno, aparece de manera muy reiterada, pero también con diferentes discursos, algunos como más exclusivamente una visión más puramente endógena, otro más exógena y otro que lo integran, ¿no? Entonces, también esto de pensar la diversidad de discurso al interior de una profesión como la psiquiatría, cuando a veces de las ciencias sociales tenemos el prejuicio de que todos ven más o menos lo mismo, ¿no? Y cuando estás en el campo me parece que te das cuenta de que hay múltiples visiones sobre un fenómeno que también, creo que también insisten en esto, en pensar la depresión como también otro fenómeno psíquico, por así decirlo, de, resaltando la complejidad y la casi imposibilidad para definir de una manera estricta, ¿no? Entonces, también acá en lo que yo encontraba parece mucho esto como cada caso es singular, cada depresión también, por así decirlo, se vuelve único, tiene su especificidad. Así que bueno, por eso solamente ese comentario, me parece muy interesante todo lo que venís trabajando y por eso creo que también seguramente, ojalá que podamos seguir como participando o teniendo actividades en conjunto.
Sí, bueno, sí, sí, gracias, es muy interesante que that in different places we have same representation. I always wondered that, like, because when I started this, I was like hypothesizing that I found like I would have found like different perspectives in psychiatry from doctors, which I found. I mean, schools are different also in Italy. Like there are some different, I would say, more styles than clearly schools in terms of really strict divisions. And I expected to find like the psychoanalyticals, the social psychiatrists, and the biological psychiatrists, they're divided, which I didn't found because like seems like nobody at the moment, as far that I've observed, like will take a specific stand, like refusing the others at the moment, as far as I've seen. But I cannot exclude this exists. So yeah, I cannot say I did just this to my interviews were it became boring to do after a while because they were always saying the same. Like I had saturation since the beginning. Let's say it's first interviews, copy paste all the others. They were like saying the same exact things about the like training, and then they had to learn other things and so on and so forth. So yeah, thank you for the comment.
Gracias, Esteban, también por tu participación, sabiendo que estás con muchas cosas, así que hayas podido llegar a esta primera parte y hayas podido intercambiar con Gabriele es muy valorado. Yo tengo otras cuestiones para preguntarte, para conversar. ¿Estás de acuerdo, Gabriele, que continuemos? Si alguien más tiene alguna idea, por supuesto puede participar. The last part of your presentation, when you were talking about the interventions, yes, I wonder if there's any other type or social or communitary net for these people apart from the clinic, they can be included, and because you were talking about a very robust net of social workers trying to include them in programs, but I wonder, it's just
that's a good point, actually. How to maybe also include this in my thesis. So the answer is no. So let's say
but that's a finding. I mean, that's a result itself. There is no.
I mean, it's hard to say. I mean, the point is that I studied like a big city, so at least for Italy is a big city, and goodbye, and so there are like all these maybe. Like some doctors talk me about working in small towns or smaller contexts where like social cohesion is different. Even like even some of the Trieste, Basaglian, they still have some new project which are like mostly based on the fact that it's a small town, a small city. And there is a lot of like community help, and so they work because they are like in a different context as well. When we come to a metropolis, it's way more difficult. The point is that for this kind of problems, which are considered like less problematic compared to schizophrenia or bipolarism or other things, which I understand it's true. I mean, the amount of resources that the clinic is like, if you see like, let's say more than half of the people coming for the first time to a clinic have depression or anxiety problems, okay, but still they just go there, take whatever they have to take, which is medication or encounters or psychotherapy, and then they're free to go. There's not much to do. People are continuing their life. While with people with psychosis or other types of needs, it might be way more complicated, and they require more interviews, more help. They might have educators, and there are many projects also to help people with that, like many activities like from this clinic, like, I don't know, art activities, like going out, doing things and re-socializing. The point is that the people there working there, they say that this kind of services are quite pretty isolated from the rest of the context of the city. So no, not even like patients group, not much. I mean, these kind of services, I think they're well think in some ways, but they're like not bounded to anything else in the context. They have some other like it's all in the hand of the hospital and the doctors. So they have like for instance, in the places I worked, some activities to help people to finding a job and so on, which is something great. So that connects outside, but it's also in the hands of the hospital.
No, it was only a question, because I remember that we've been talking about the thesis, and you said you wanted to include more arguments on the conclusions. So maybe that could be a thread you can include. The more severe diagnostics are more related to other programs and things. And I remember Esteban, he left now, but Esteban, his fieldwork included peer groups on depression. There's nothing like that. There's nothing.
I don't know, as far as
at least not in those clinics, not in the two clinics you included in your fieldwork. Okay.
peer groups exist, but they are based on something else, like young people peer groups, for instance, or people with other types of diagnosis. Not much.
Okay. 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 Thank you. Thank you for that. Aprovecho que está Sofía, que está interesada en formarse más en cuestiones de sociología y antropología médicas, and I want to ask you, and you can share with us in a more relaxed way, how was she wasn't, I asked you this question before 2 weeks ago, and I wonder again, I ask you again, how was all the ethical part? Did you have to include your project to the director of the clinics? Because I told you before, it's just incorporating again all those things that we were talking about. It's very difficult for us. So the ethical parts, we have to include it in an ethic committee, and we have to include all the project and talk about it very detailed, in a very detailed way, with the director of the institution. How was for you? Because you even acceded to the medical records, which is, I think that here is a very complex thing for us as social researchers. So maybe you can share with us.
I don't know if it's like I just been lucky or so I don't know if I think I was not thinking to do this at the beginning. I thought I would be based my study only on the first part that I showed, basically, and maybe studying something else more into like observing maybe a couple of interviews, maybe seeing how they are made clinical. But in the end, I got access to this. Of course, everything is like super confident, and I have to, of course, in my thesis now I presented you saw where is the, but I will not say which clinics are.
Anonymization.
Yeah, but I think that in some way it will be interesting also to provide in the things I will write, like articles and so on, where are those clinics, but I will not. So it will be like more anonymized in that sense. So yeah. Coming to this, I got access because I found like a gatekeeper, basically. So, that was interested in this, and there is actually the thing that helped me is that there is like a lot of research in hospitals made from psychiatrists, which are like using what they have. Small research, I would say. It's not like something very, and so people are used to get access to this. There is a lot of volunteering in the hospital as well. And I had to just sign some documents to take part to this. Apart from this, I would say that yeah, I mean, another hospital which I asked, they asked me to give the how you call it, the ethical committee approval. Yes. Which the problem is that I don't know here, but there is like that you have to follow some standards which are not much suitable for the qualitative research, because they're always asking for outcomes, treatments, for the population, and so on, which is a problem because then you don't know how to make them understand, because ethical committees are mainly ruled by doctor, even in university, even if you're like in sociology and you want to. So this is just something that I was questioning. Before coming here, I was doing my exchange in Sweden, and in Sweden now they have mandatory ethical approval for any kind of thesis, even though you're like doing something that not requires it. It's mandatory now, and it's very
in social thesis or in
any kind of things. Okay. They had some problems with there was like something bad that happened for the doctor who did some experiment on person that went very bad. And so after that, they decided to put this ethical committee in everything. And sometimes it's a problem because then it becomes like getting into it very closely. So the point is that I don't know if this would be, I mean, they're making problems to people for doing the research, but still I know that in that culture they have much more of this kind of study than in Italy, for instance. So I think it depends. I think it's not just a matter of like relevant and sensitive information. Of course, there are some other contexts that I will never be able to observe. Like recently, I was in contact with a student that wanted to do observation, and he told me that he wanted to observe psychotherapy session, and I told him like that's not the case. I don't think you can do that. While for psychiatric interviews, it was like there are always like people there in the room, like other people observing, like as trainees or something else. So yeah.
Yes, yes. And the last thing I wonder, in some cases here, when you apply, when you're accepted to conduct a research in some institution, not in every case, but in some cases, you have to arrange some kind of activity after you publish or you finish your research. Can be un taller, I don't know how to say it, un taller, un grupo, when you...
workshop?
A workshop, some kind of activity in which you include your findings and you share them with the community, maybe the professional community, maybe the patient community. It depends on your objectives. See, so maybe that's not the case for you. They are not, they don't expect anything, some report. Anything.
The agree is that maybe I will publish something with the psychiatrist. I don't know. Actually, I would like to.
I don't consider anything bad. I'm just talking about the different styles, you know.
Just no. I take your question to what can I offer? Because sometimes I think about it like, okay, I'm taking. I don't know if how can we involve patients, or if also there is the need to involve patients for this, or do something at least with the, I don't know, give back to the psychiatrists. I'm not even sure about that. Like if this is.
I don't consider it mandatory. There's some in the research that don't include that aspect,
because I think it's important. But I think that somebody would probably be interested and somebody not, of course, that's always. But apart from that, also, like, how and what can I say, and like for what reason? Because I mean, it's it will give like I don't know, maybe it will help psychiatrists to learn about some things involved in that.
In some cases, they are interested.
Yeah, no, I think they are, but maybe there is some resistance. Maybe they feel like betrayed. I don't think that I'm speaking bad of psychiatrists in my thesis.
All the options are true. Usually, all the options are true.
I might disagree with something, but I'm saying good things because in the end, I work with people that are doing their best, and I respect them, and I think they're working good. I just point out some problems which I mostly found structural.
Yes, you're not a detective trying to find them in a illegal practice or anything.
No,
I understand.
In general, I realize that some of the problems that I like, for instance, like overprescribing pharmaceuticals instead of psychotherapy, I said it's more a structural problem than a...
Yes, we shared this. I remember 2 weeks ago you were talking about this because you said they have insufficiency of psychologists, that there are not many, and there's no, they couldn't keep up with the sessions because they would have to work like 24/7. I remember you were talking about that. They have more psychiatrists than psychologists, and that was a structural problem in the clinics. And the last thing, of course, it's for closing maybe, is, do you remember anything particularly that was unexpected for you during your fieldwork? You were talking about that maybe you were expecting a different view from the psychiatrist, maybe a more encloser one, but maybe another thing you remember you want to share with us, because you did a very detailed fieldwork in a prolonged fieldwork. So maybe you remember anything.
I have to think of what I was thinking at the beginning and what I was thinking at the end, maybe. I don't know. I mean, in general, some of things I was surprised. When I started, I had like, as I said, some hypotheses got like completely changed, which I think it's great because in that sense,
of course, that's the best part.
Not forcing. I remember that I was from other social scientists, actually. They were trying to tell me, no, you don't have to study representation. It doesn't matter. They will all share this vision, and it's the DSM vision. Of course, it's not like this. And I was surprised about the fact that it was, as I said also 2 weeks ago, mostly going from the symptoms to the treatment and without going into the diagnosis. The diagnosis is not always happening. Of course, they know what is happening, but they're not like giving a specific one for it's not essential. Maybe they are for like for the record, but it's not essential in that sense. It's essential to understand the patient in that sense. I don't know what else I was surprised. I have to think about it. Like I think like how I was at the beginning and how I was at the end. It's tiring. That's I was surprised. I didn't know it's tiring to do this.
Yes. And listening
doing the fieldwork.
Those interviews.
And sometimes I didn't feel. I also like realized if I have to speak, I also in writing like how you say an appendix concerning how I was feeling in the fieldwork. And
that's the reflection, self-reflection.
Yeah.
I mean,
and I was surprised about the fact that in the context where there were more problems, that also has less resources, which is weird because they're like should be the opposite. I was feeling better. I like the idea that people were because the people there, the organization was better. The people were not the organization was like the people were like there was more cohesion in that sense. And even though you were like facing a very distressful situation, that helped me to stay. While in the other one, even though there was like less problems in that sense, there was still some kind of tension and like a more formal and strict environment that didn't help me in that sense. To also when you face like patients with problems and everything else.
Okay. And now the last one to share with you is, even though you did an extended work and you're just finishing the writing of the thesis, do you consider that you would like to keep on working on these topics? I don't know, maybe depression, but other diagnostic, because you were talking about the lack of antecedentes, no me sale la palabra ahora. And you said in Italy there's no a robust tradition.
Nobody did this kind of stuff. Like nobody did observation in this clinic. I know really a couple of persons who did this similar work in other clinics. But
I remember that. So would you like to move on to another topic after this?
No, I would like to continue. I would like to finish publishing, start publishing this stuff.
Yes, start publishing.
and see how it goes. I would like also that the part like about the intervention and think about what to do. That's something that I would like to explore more also, not just the scientific part.
Of course. Okay. Thank you very much. Muchas gracias, Gabriele. Siempre es muy interesante escuchar estas características, no solo la cuestión formal de llevar adelante una investigación de doctorado y estar culminándola, que eso nunca hay que take it for granted, never take it for granted. It's a very difficult thing, it's a hard process, and it involves the self in a very profound way. So you are finishing that, and that is, I think, to celebrate itself. But even having said that, it's also very interesting to share all these, remember all these, the opinions on how was the process and the differences between the styles in the academic community. That's why I always include the ethical aspects, because I knew for previous conversations that is not the case in Italy, but here we have a lot of difficulties as social researchers. So it's always very interesting to share these kind of things. And of course, you are invited to continue participating next year. We are almost finishing the planned activities. We have one more. And acá pone Sofía. It was really interesting presentation, Gabriele. Thank you so much for sharing it with us. She's working on anxiety. That's why I said maybe depression, anxiety are topics which are very interesting.
Yeah, thank you for inviting me, and this was great. And also it's very nice to also hear the other presentation that I heard and all this, like I say, format of, yeah.
Muchas gracias. Julia, no sé si vos querías hacerle algún comentario. She's a pharmaceutical.
Okay.
She's not, she's the kind of...
¿Se enferman? Yo bueno, te voy a hablar en español porque...
Sí, bueno, no problema.
Okay. No, la verdad que te agradezco. Yo no soy del área de las ciencias sociales, soy farmacéutica y hago investigación en el área de farmacia y ni siquiera estoy trabajando con salud mental. Entonces, como que para mí este espacio, bueno, este año fue como, bueno, abrir mucho la cabeza, me quedan resonando muchas cosas.
Ok, bueno.
Pero bueno, te agradezco, muy linda tu presentación. La verdad que como yo no soy del área de las ciencias sociales, ni la psicología, ni nada, como bueno, desconozco lo que se hace en otros lados del mundo, por ahí sí algo de lo que se hace acá, pero en el resto no. Y bueno, te agradezco, me parece genial que hayas venido acá a hacer una pasantía, que por ahí, bueno, viste que nosotros decimos, ¿cómo vienen acá? Nosotros siempre tratamos de ir hacia afuera. Y bueno, los trabajos en colaboración o ver que las realidades en un lugar y otro son similares, todos los puntos donde se tocan, bueno, a mí me parece fantástico. Esto de poder interaccionar con gente de otros lados para mí es maravilloso. Así que bueno, te agradezco.
Bueno, gracias.
Bueno, si no hay ninguna otra consulta o intercambio y estás de acuerdo, Gabriele, podemos, si estás de acuerdo, damos por terminado el encuentro.
Sí,
Yo
sí.
ahora voy a dejar de grabar para que nos despidamos.